Well, it's very exciting to be able to talk to you about whatever I want for 20 to 25 minutes. So, in the realm of oncology, of course, I could talk about oncology topics all day long. So it was very difficult to figure out what can I really attack in this short amount of time, especially for those of you out there, since very nice mixed topic with these 3 different topics that many of you probably don't practice in oncology. So what can I say that can be pertinent to everyone? Just to highlight some of the new drugs. The oncology field is growing exponentially, so incredibly fast it's hard to keep up with. I have, doing an oral chemotherapy program at our institution, I have a new pharmacist who's starting to help me with it, and there was 3 drugs just approved in the last month and a half, and I'm naming these, she's like, what drug is that? How have I not ever heard of that? And I think it's because it's evolving so quickly. So I'm going to try and highlight some of the new drugs that have been FDA approved this year, although not all of them because there's not enough time to do all of them. So first I'll talk a little bit about carfilzomib, new drug, and compare it to bortezomib in the treatment of multiple myeloma. And then talk about just a select few of the newly approved tyrosine kinase inhibitors and 2 other oral anti-cancer agents. So first let's talk about carfilzomib. So what is it? For those of you who worked with bortezomib, very similar to bortezomib in that it's a proteasome inhibitor. So proteasomes are in all of our cells, so not just tumor cells. Part of the ubiquitin proteasome system, so that degrades highly regulated proteins. So carfilzomib will attach to the 20S and the 26S proteasome and do inhibition there, which leads to apoptosis. Highly selective for that. It was approved in multiple myeloma patients. They do have to have failed other therapies, 2 other therapies, one of them including bortezomib and immune modulating agents, which would be lenalidomide and thalidomide. The good news is, very easy for the patients to qualify for that, as bortezomib and the immune modulating agents are frontline therapy for patients with multiple myeloma. Interesting thing about carfilzomib, and I'll compare it a little bit more to bortezomib, because bortezomib works the same way. So what might be special about carfilzomib? Well, it's a little bit more selective at the chymotrypsin site in the proteasome than bortezomib, and it actually has less off-target sites. So we have a little bit less of some of the side effects that are actually dose-limiting with bortezomib, and I'll talk about that in a little bit. Just to briefly highlight some of the data that got carfilzomib approved, the top 2 I want to point out to you are for the FDA-approved indication for relapsed refractory multiple myeloma. And I'll talk about the 3rd one in a second and why I included that. So looking at the dose, I'll really highlight the first trial with Siegel. It was a phase 2, 257 patients. And so for the first cycle, they used 20 milligrams per meter squared for that whole first cycle, which is the whole first, basically, month of therapy. The patients are getting carfilzomib on days 1, 2, 8, 9, 15, 16, and then they do a week off. And then they'll start their next cycle. So we think of the cycle as in 28 days, but they're really only getting therapy for those first 3 weeks. Then starting the second cycle, they'll titrate up to 27 milligrams per meter squared. So that's what the first study with Siegel looked at, that dose. Overall response rate, 23.7%. Progression-free survival is 3.7 months, and overall survival 15.6 months. Now you might look at that response rate and say, 23.7%, it's not very good. In the oncology world, as many of our drugs are FDA approved on phase 2 data, and approved with surrogate outcomes as the primary outcome, usually they have to prove additional data later on. But this is actually pretty good. Most of these patients had undergone a transplant. Many of them had 4 prior therapies. So that response rate is actually relatively good in that patient population in that setting. Although, for majority of other studies, if I think about non-oncology studies, that would look a very poor response rate. The VIGE study did very similar. They had a small group, 35 patients, and they were looking at the lower dose before they were dose escalating. Very similar response rates that we saw with the Siegel study. Really want to highlight the 3rd study with Dr. Jakubowiak. This one was actually done at it was a multi-center, but this was done with Dr. Jakubowiak, was at the University of Michigan. It's a phase 1/2. Now this is for new diagnosis patients. This is not why it's FDA approved. What they did, similar dosing, although they did dose escalate to 36 milligrams per meter squared. So they went beyond that 27 milligrams per meter squared. They combined it with lenalidomide, so with one of the immune modulating agents, and then dexamethasone, either 20 to 40 milligrams weekly. The lenalidomide plus dexamethasone are very standard frontline therapy patients for our multiple myeloma patients. What I want to show you is the complete response rate, 42%. And with multiple myeloma, not always with other diseases, we actually look at very good partial response rate, near complete response rate, and stable disease as favorable outcomes. Whereas in some cases, stable disease may not be seen as favorable, stable disease and higher in myeloma patients is actually seen as a favorable outcome. So the very good partial response rate in non-transplant patients, these patients, if they were eligible, were allowed to go on to transplant. But even those that did not, the very good partial response rate was 83%, which is extremely high. When bortezomib was first approved, these were very similar numbers to bortezomib when it was approved in newly diagnosed patients. The reason I bring this up is because carfilzomib is not even yet in the NCCN guidelines as therapy for multiple myeloma. Obviously, it will be when they update it after this year. Since carfilzomib was just FDA approved about a month ago. But I think that we will see it move very quickly from being incorporated into the guidelines as therapy for relapse refractory to probably frontline therapy. And I'll talk about in a second why I think that will be. So the dosing, let's compare it to bortezomib. So for those of us who use bortezomib or Velcade as the brand name, that is dosed usually on days 1, 4, 8, and 11, 28-day cycle, frequently with an immune modulating agents and dexamethasone. Standard dosing for that is 1.3 milligrams per meter squared, so we do not dose escalate with bortezomib, whereas we do with carfilzomib. Carfilzomib is also given IV over 2 to 10 minutes. When bortezomib was first FDA approved, it was also FDA approved to be given IV. In February of this past year, it was FDA approved to be given subcutaneously. Has some better side effect profile while it's being given subcutaneously. Carfilzomib must be pre-medded with dexamethasone. And this is not, so we use dexamethasone in our multiple myeloma patients as therapy, 20 to 40 milligrams. We're using it as a component of the regimen, not as an antiemetic or an additional pre-med for infusion reactions. But in this indication with carfilzomib, we are actually using about 4 milligrams of dexamethasone, and this must be used as a pre-medication to prevent infusion reactions, which is very different than bortezomib. But you only need to do it with cycle 1 and then the first dose of cycle 2, and that's because we're using a higher dose of cycle 2 of the 27 milligrams per meter squared. But that's a pretty big difference compared to bortezomib. We do have to do fluid boluses before and after. When we use bortezomib IV, majority of institutions are using it subcutaneous now, but previously when we did use it intravenously, we had to do this as well. So this is not entirely new for these patients, although it can be problematic for any of our patients who have heart failure and can't tolerate those fluid boluses. So the main reason I think that it will move up quickly within the guidelines is because of its adverse effect profile. So I mentioned before that it has less off-target sites than bortezomib. One of the dose-limiting effects of bortezomib is peripheral neuropathy. It's extremely significant. If you use it IV, about 50% of patients will present with peripheral neuropathy. And even using sub-Q, it did decrease quite a bit when we used subcutaneous to down about 38%, but that's still pretty significant. If you think about who gets multiple myeloma, a lot of these patients are in their 60s, so they have a lot of comorbidities, a lot of them including diabetes. So a lot of them may already have peripheral neuropathy from their other comorbidities, and now we're giving them chemotherapy on top of it that can make it worse. The good news with bortezomib is it is irreversible, or it is reversible peripheral neuropathy, unlike some of the other agents we use in myeloma. The interesting thing with carfilzomib is they saw almost no peripheral neuropathy. Quite a significant difference considering that it acts very similar to bortezomib. And I mentioned in that initial study by Dr. Jakubowiak that the outcomes were very similar to when bortezomib is used in frontline therapy to the original studies. So that's partially why I think it will move up quickly within the guidelines. The infusion reactions are unique. We don't see infusion reactions with bortezomib. When we do the fluid bolus, it's because of hypotension that they can get, but not the infusion reactions that they see with carfilzomib. Thrombocytopenia is the other main side effect. We also have that issue with bortezomib, so I don't see a difference there. Fatigue, nausea, vomiting are similar as well. Hepatotoxicity, there is some warnings for pulmonary hypertension, which is interesting. Sometimes I wonder if that's related to some of the different fluid boluses and the cardiac failure as well. But those are warnings with the drug. So overall, I think this will be incorporated very quickly. We've had many of the studies open at our institution for several years, but we quickly converted a lot of those patients over and have been using it commercially pretty quickly. Cost, since I know cost data can often be a good question. So for these, the carfilzomib comes in 60 milligrams. So if you think one dose is 20 milligrams per meter squared, majority of patients these days are close to a BSA of 2. That could be one dose for a patient. About $1,600 is the WAC. Velcade comes in, bortezomib comes in 3.5 milligram vial. Typically with those patients, we don't use a whole vial for any patient. Majority of them, we're using partial vials. But for a whole vial of 3.5 milligrams, it's about $1,500 is the WAC. So relatively similar in cost comparison. Next, talking about, as I promised, some of the new oral anti-cancer medications. While carfilzomib was being given IV, I really think that the future of cancer therapy is going to be with oral agents. And I think this is just evidenced by the number of them in clinical trials and the number of them that have been FDA approved this year. I'm just touching on a few of them because there's no way I can talk about all of them, even within probably an hour time frame. So first talking about two prostate cancer medications. We've got abiraterone or Zytiga and then enzalutamide Xtandi. Abiraterone is an older agent, was now FDA approved this year, but I wanted to show it for comparison to enzalutamide and Xtandi, which was just approved in the past month. And the reason I also want to highlight abiraterone is because I've been seeing it used much quicker on in therapy than what is FDA approved for as well. Both of them are essentially FDA approved in the patients who are metastatic castration resistant, who have received docetaxel. So they need to have received a docetaxel therapy, or you will get it rejected by the insurance for coverage generally. A little bit different mechanism of action. We have abiraterone, which inhibits the 17-alpha hydroxylase, whereas enzalutamide actually works at the androgen receptors and inhibits the androgen receptor nuclear translocation and interaction with DNA. And I think it's an important distinction because it'll play with the side effects a little bit. I'm a picture person, so I like to show pictures when looking at the mechanism of action. So you can see abiraterone is working here, so converting with the 17-alpha, also with tumor synthesis in the prostate cancer patients. But then you can see enzalutamide working intracellularly at the androgen receptors, and then at the nuclear localizing site and the DNA binding. One of the big differences, the reason I really wanted to point out the mechanism of action of both of these, is that abiraterone must be given with prednisone 5 milligrams twice daily. This is a big catch. If you get a prescription with abiraterone and you do not have prednisone, the prescriber needs to be contacted. This happens a lot. You will also frequently, some of the insurance companies, if they don't see an active prednisone prescription, they'll trigger back a prior authorization simply on that basis alone. This is because of the negative feedback. So if we start blocking that testosterone at the CYP17-alpha, you're going to get a negative feedback, and you're going to have ACTH that's going to increase. And so we see hypertension and other side effects, edema with abiraterone that can occur if they are not given that prednisone along with it. So that's important to try and preemptively stop that feedback from occurring. Both of them, each patient will take 4 tablets a day. So abiraterone patients, it's a 250 milligram tablet. Enzalutamide is 40. So they'll take 4 a day at this, all 4 tablets at the same time. Abiraterone must be taken on an empty stomach. Enzalutamide can be taken with food. All of the oral agents out there for cancer, the new tyrosine kinase inhibitors and these 2 agents, are all CYP3A4 substrates. So warning lights should go off every single time you see one of these drugs for patients because there's almost always going to be drug interactions. I don't know how they're going to get around that yet because I know most of the ones in clinical trials are also CYP3A4 substrates. But then they can also have effect on other agents. Enzalutamide is also an inducer of 3A4, 2C9 moderate inducer, and 2C19 moderate inducer. And actually, I've had concern from several patients. One in particular is on a fentanyl patch, and fentanyl, you know, being a substrate, it talks about inducing that fentanyl might not be as effective. So I had a patient extremely concerned who's recently started enzalutamide and knows on his fentanyl patch that his fentanyl isn't going to be as effective. Actually, by the package insert, they recommend not using them together. I don't know that I agree with that. I think you can absolutely use it together if you have a patient stable on a fentanyl patch, but know that you may need to go up on the dose when they're taking enzalutamide. Looking at the overall survival in studies for these patients, so pretty similar, abiraterone 14.8 months versus 10.9 months when compared to placebo. Enzalutamide 18.4 months versus 13.6 for placebo. So pretty similar. No head-to-head trials between these two as of yet. I don't know that we'll see that either. So side effects, abiraterone, I've had a lot of experience with this agent. Very, very well tolerated. Edema is probably one of the main things we see. I see a lot of fatigue with these patients, although it's not specifically listed. Maybe some joint pain. The hypokalemia and the hypertension generally result more in if they're not getting that prednisone given concomitantly with the abiraterone. So if you're giving the prednisone, you're unlikely to see those. Hepatotoxicity can also occur, but it's pretty rare. Enzalutamide thus far, I feel like it's flying off the shelves as fast as our physicians can write prescriptions for it at our institution. One of the major side effects I want to bring up, again, because I had a patient's wife called me extremely concerned because of seizure risk. So they saw about 8 out of 800 patients, they had about 5 patients who had seizures. The placebo group had none. But if you look at the AFFIRM trial in the New England Journal that initially published the enzalutamide trials, if you look closely at the group that had the seizures, there is some explanation. 2 of them had brain mets. Another one had had seizures before. Another one had accidentally received lidocaine intravenously prior to having a seizure. So it's very rare. Could happen, but I think the risk for majority of our patients, I think you can reassure them that the risk is pretty low. Very similar in the fatigue and joint pain with abiraterone. Seemed like there was more hot flashes reported here than we typically see with the other agents, and possible risk of infection. So talking about just select new tyrosine kinase inhibitors. So just to remind those of you who haven't seen tyrosine kinase inhibitors before, within the cells we have the dimerization at the tyrosine kinase that needs to occur. They need to dimerize in order to become active and activate within the cell. So tyrosine kinase inhibitors will inhibit this dimerization so that you can't have the downstream actions that will work inside the cell and promote proliferation. In a nutshell, that's how they work. There's multiple tyrosine kinase inhibitors and targets that we have. BCR-ABL, or the Philadelphia chromosome positive patients. This happens at chromosomes 9 and 22 when there's a translocation. Bocetinib is a newer agent that's been approved. We have 3 agents on the market currently that affect the BCR-ABL. While many of these agents, especially when they first started coming out of tyrosine kinase inhibitors, we called them targeted therapy. They're sort of targeted therapy. They affect tyrosine kinases. They can happen multiple cells. They don't just target the cancer cells. And they usually are not targeting just one tyrosine kinase. They tend to be multi-kinase inhibitors. It's probably more of an accurate description because bocetinib also inhibits the SERT kinase family. So let's compare it. I think most importantly, when we get these newer agents on the market, is how do they compare to what we already have? So bocetinib, these are the other 3 agents that we have currently FDA approved. So bocetinib is approved for Philadelphia chromosome positive CML patients who have failed prior therapy. Imatinib, dasatinib, and nilotinib, or Gleevec, Sprycel, and Tecfidera are the other 3 agents on the market, all also FDA approved for the same indication. Imatinib and dasatinib can be used in newly diagnosed CML patients, and imatinib and dasatinib can also be used in Philadelphia chromosome positive ALL patients resistant to prior therapy. One thing to point out, though, imatinib was the first agent in this class on the market. Dasatinib followed, and then nilotinib followed. And they've been adding indications on as they've been going. So I won't be surprised if nilotinib and bocetinib are able to add on additional indications from where they work. Briefly, just to show you the efficacy that we've seen with bocetinib, I pulled one trial. And these were chronic phase CML patients who failed imatinib and dasatinib, or they failed nilotinib. So I think this is important to note because what can we use in these patients as they start to fail? What we know with these agents is there was a lot of mutations that occurred. There's one in particular, it's a T315I mutation that actually none of these agents, including bocetinib, will work at. When patients present with pH-positive CML, or ALL for that matter, we actually will run to see if they have the T315I mutation, because if they do, none of these will work and they'll need to go on a clinical trial. But it's interesting to see if patients failed these, could we use sort of kind of like a me-too agent and will it work in these patients? And we see that actually it will. So patients that got bocetinib, 32% of them had a major cytogenetic response, 24% of them had a complete cytogenetic response, and 73% of them had a complete hematologic response. And 83% had the two-year overall survival. So I think it's interesting to know that even if our patients fail through these, again, provided they don't have the T315I mutation, that bocetinib could be another option for them. It's taken once daily with food. We do have digestion and hepatic impairment. Like I said, 3A4 substrate and PGP substrate and a PGP inhibitor. A lot of these new tyrosine kinase inhibitors you cannot take with proton pump inhibitors because they need acid environment to be absorbed. Between these 4 agents, bocetinib and dasatinib are the 2 agents that cannot be taken with a PPI. Nilotinib and imatinib actually can be, so that's important to note. Many of these patients can also be on high-dose steroids along with these agents, so that's something we want to take into consideration. Adverse effects, pretty similar across the board. Obviously, they're all going to cause myelosuppression. GI side effects ranging from diarrhea to constipation, usually diarrhea, although I will say they're all very well tolerated. You don't need to give them prophylactic medications for nausea and vomiting. Every once in a while you get a patient who has trouble tolerating one of these, but generally no. Fluid retention is not uncommon. Something that we've seen with nilotinib, it has a black box warning for QT prolongation, so it's interesting to watch these agents to see if we have any issues with that. With bocetinib, they did not see any QT prolonging in the studies, so that's important to know. Next, another agent that was just approved in the past month, and I think was just available for purchase probably a week or 2 ago, is regorafenib or Stivarga. So like I said, multi-kinase inhibitor. This one inhibits a lot of different kinases. I highlighted all the VEGF receptors because that's mainly what it was FDA approved for. Probably its big target in being used in colorectal cancer patients. Very interesting because not only do you have to fail one therapy, but you're having to fail multiple therapies to be able to use this. So this is something that's more going to be 3rd or 4th line in colorectal cancer patients. It's taken once a day. Looking at the study by Grothy and colleagues, overall survival is interesting. While it's not a surrogate endpoint, you can see that you buy about 1.4 months. So about 1.5 months is what you can gain from this agent. Keeping in mind, though, it is a 4th or 5th line agent at this point. So you can ask yourself how impressive you think that is. Progression-free survival, get yourself 0.2 months. Adverse effects, hand-foot reaction, not uncommon with these agents. Hypertension, also not uncommon. Although some of the other agents, it's more common since we're inhibiting VEGF. Fatigue, I don't know what study at this point, when you're 4th or 5th line with cancer patients, you're not going to see fatigue, but that's reported. And hyperbilirubinemia as well. Dosing, days 1 through 21 on a 28-day cycle, so you're getting a week off. Very interesting that they recommend taking with a low-fat breakfast, and this is exactly what they recommend taking it with. So they give you recommendations in the packages for what they constitute a low-fat breakfast. So I'll let you read that with the calories and fat information. Again, it's a CYP3A4 substrate. It's also an inhibitor of UGT1A1. Some of you may be like, I don't normally worry about that, and you don't, except in these patients are frequently getting irinotecan, which it does go through UGT1A1, so that's why I point that out. It's not approved to be using irinotecan. They should have failed irinotecan before getting this, but you never know what you might see. And with that, I think I finished with a couple minutes to spare. But I will turn over, I think, and take questions at the end for everyone.
So I have a disclaimer before I get started with my program and everything, is that initially this was my topic. About 8 months ago, I was asked by the Education Committee of MSHP to do a program on, for the clinical pearls presentation here. And so the PGY1 resident, Chelsea Grumbier, that we had at the time, and I decided that procalcitonin would be a great topic to do it. And so we thought, well, let's go ahead and do this. About a week ago, I thought, you know, we are seeing a lot of patients with fungal meningitis. And wouldn't it be good, remember, I've already had my slides all together and everything already, so I've had it all together. So wouldn't it be kind of interesting to go over that, because it's a lot more pertinent, even though procalcitonin to me is something that I enjoy and it's something to look at. And we're actually our current PGY1 resident will be doing that in her project. So it's something that we're going to be looking at, but I thought, gosh, let's get it together. So I called Mary Farrington, who's the coordinator of this, and said, you know, is there any way I could incorporate that into my presentation? She said, sure. But you still need to go over a little bit over this, too, so because we've got questions on the post-test with this. So I said, okay, I can do that. So after a long weekend and a very short week, unfortunately, was able to get it together, some slides together. You know, the bad thing, again, is that there's not a lot of information out there. The good thing is that there's not a lot of information out there either. So what I'll be covering is a few published articles on this, mainly everything coming from the CDC like that. So I'll get started. But first thing I need to do is, again, refresh with you a little bit of procalcitonin, not very much. And by the time you get down to the 4 slides, you'll know probably nothing about procalcitonin, but you'll probably have the answers to the questions that need to be answered for this post-test. So this is my disclaimer, faculty disclosure, so no real financial relationship. So really, the procalcitonin, the objectives are probably going to be more than anything, my whole presentation on this, is that the role of procalcitonin, describe that in the identification of bacterial infections. Remember that for a post-test question. Recognize the utility of procalcitonin in limiting the duration of antibiotic therapy. So these are a number of biomarkers that we use out there for really determining different inflammatory responses, inflammation, things like that out there. Probably the most common that we use for infections right now would be the WBC. Neutrophils, obviously. We use CRP a lot for those chronic infections, but it is just more so an inflammatory marker than anything else. And as you can see at the bottom here, we do have procalcitonin or PCP, and you can see that you usually see a relationship with bacterial infections. Important for the first question. This is what actually procalcitonin looks like, 116 amino acids like that. It's cleaved once it's released to calcitonin to lower calcium levels like that. It is pretty specific for bacterial infections. So with calcitonin, the release is usually done in the thyroid gland itself. With bacterial infections, we'll actually see an increase of procalcitonin. Just about every organ in the body releases like that too. So we see a high concentration very rapidly associated with it too, as you can see here. And then with infection, and then reaches a peak. And as the infectious process, being usually bacterial infection, starts to abate, we'll see a decrease pretty rapidly in the procalcitonin levels. You can see here a number of studies that were done. The majority of these studies were done in Europe, both observational and interventional studies. You can see the majority of those were done, and a lot of good information in the human-acquired pneumonia, healthcare-associated pneumonia, COPD patients, even ventilator-associated patients, too. We do see some in the septic patients, and then other areas along the way, too. So, in conclusion, as I said, it was very short on procalcitonin. And remember that procalcitonin is used as a tool. It's not used by itself to diagnose bacterial infections, but it's actually used as a tool, in fact, okay? And actually it's for bacterial infections. So I think if you remember those 2 points, you're going to do okay on the post-test with my questions. So let's go now into fungal infections. I think I have enough time. Okay, good. Fungal infections, secondary contaminated steroid injections. So again, we're seeing a fair amount of patients up in Traverse City, and I'll explain a little bit. In Ann Arbor, obviously, Mercy Hospital there, they're seeing a lot more patients than we are. I talked to Kim from there, who really explained the number that they have. They actually have 50 inpatients right now that have fungal, either meningitis or septic arthritis associated with it. We don't have quite that many. We've had about 20 overall. Between the two, I think we're seeing a fair amount. I think they're cohorting the patients from the southeast area in your hospital. Is that correct? Okay, they are. So that's why they're getting so many down at St. Joe. My one objective that they actually asked me to put in with this, before they knew I was going to do most of my presentation on this, is just to identify the antifungal agents that are currently being utilized for treatment of patients with confirmed or suspected infections from the contaminated methylprednisolone acetate. So this is a slide that I thought, oh, it's not a good slide, and I always was taught never use a bad slide, and never apologize for your slides. But really, this came out from, Julie Bosford sent this to me not too long ago, and it was from the ISMP, and it really explains kind of what we've had of contamination over the years in different cases. The last one is on the bottom, 2012, the number of cases. Obviously, this was not updated, but it says at that time 200 patients were affected by this. Right now, we're over 400 cases. But you can see along the way here that we've had a number of them, even all the way back as far as 1990, contamination from some of these pharmacies that are compounding like that. And it hasn't been new to Michigan either. We've had some cases in Michigan, and even that case was from contaminated methylprednisolone. Actually, there was an article in Annals of Internal Medicine recently that looked at that, saying, you know, methylprednisolone acetate is one of those you really need extremely sensitive compounding with that, sterility associated with that, to make it so it's not going to be something that will be contaminated with that. So you can see we do have a whole bunch of contamination. It's not the only one in here, but obviously this is the biggest one, and it's a huge concern. This is an article that was in Morbidity and Mortality Weekly Report in October 19th, and it actually goes over a lot of good information in here too. Obviously, these are the vials. Those were the lot numbers that we had from the contaminated methylprednisolone with it. This is where we're at as of yesterday with the total number of cases. You can see here that Michigan is number 1 in the total number of cases. Tennessee was the first case. The index case was in Tennessee, and that patient expired secondary to that. Tennessee still has a total number of expired patients or deaths associated with it. We're number 2 on that. I was told that as of today, that it was just updated about an hour ago or 2 hours ago. We do have 112 cases now in Michigan. We're up to 406 total cases in the United States in 19 different states like that too. So it's still progressing. It's not something that's going away as of right now. These are again the states that we're seeing, and you can see again in Michigan as of yesterday was number 1, but it is spread out primarily through the Midwest and the Eastern patients or states like that too, so we're seeing it. So this is a little bit of a timeline associated with it that we're seeing. You know, back in September is when the first case was identified, the index case. From that period of time, September 25th, then we saw when the NCC, New England Compounding Center, stated how many doses that they were actually sent out. It was 17,500 to different facilities throughout the country, about 75 facilities in 23 states. Now we have cases, like I said, in about 19 states right now. The 26th of September, they had a voluntary recall of all the methylprednisolone lots like that. And then 27th, it was up to 8 cases at that point. You can see the progression of this. By the 5th or 6th of October, NECC was, they said, a voluntary recall of all their products that they had back to January 1 of 2012. And then October 10th, you can see here that the potential number of patients that were affected by that, exposed patients, about 14,000. At that point, we had 12 deaths and 137 cases. So these are the centers in Michigan. Not to exploit these, but there's a number of centers around Michigan that we saw this administration of it. Again, one was in Traverse City. It's not affiliated with our hospital, but it is. Some of the physicians do work out of this clinic there. We had a total of 800 patients that were administered the methylprednisolone and 1,100 doses associated with. These are the lot numbers. So we've had, again, the majority of our patients that we see have come from our clinic, but we have had some from Brighton that have been up to Traverse City and have been admitted also. We haven't had any deaths in Traverse City from this as of yet. So with all this hype about the methylprednisolone, obviously this is going to occur. These are all many of the lawyers or attorneys out there that are kind of jumping on the bandwagon. I can kind of see it on both sides. These are patients that, they had no idea they were getting into this. They had no idea that these were going to be contaminated products like that, which they're administered. On the other hand, obviously, when you talk about, we have stated as spinal injection meningitis attorneys now that we have. So obviously they're jumping on to make some money, but on the other hand, these patients usually don't come in for 1 or 2 days with an infection. They're there. I've had patients there for weeks on end now. So they're very sick patients with meningitis or septic arthritis, being some of the other ones that we have associated with. But these are very sick patients, and there's sequelae associated with it. We've had strokes associated with it. So they're, again, very sick. And even when they do have treated, when they're discharged, they're going on medication, usually Voriconazole, for a significant period of time, probably up to 3 months therapy with some of these patients. And this is not an inexpensive medication. We figured out for one patient that we had, the first patient we had discharged, he was getting the maximum dose orally. And unfortunately, he didn't have a prescription coverage. He didn't meet our program for our indigent drug program. And it was going to cost him $16,000, over $16,000 for the Voriconazole for the 3-month period like that. So and even though there's a generic available at this time, it still has not come down significantly. So this is very expensive. Most of them actually have prescription coverage. But again, even when they have prescription coverage, unfortunately, many of the providers need to do a prior approval or contact them to indicate that this is not the normal use of Voriconazole that we're seeing here. This is up and above that. So it takes the first patient we had was rejected. They said no, they're going to have to get that out of pocket for paying for these, and then we were actually able to resubmit it and get it approved then finally. So these are the 4 categories that the CDC is looking at with that. So fungal meningitis, obviously, basilar strokes associated with it, spinal osteomyelitis, or epidural abscesses, and then lastly, which we're seeing a few cases now, are septic arthritis or osteomyelitis of the peripheral joints where they've had it injected in here too. You can see the SI joints right here. Okay, so you can see here the SI joints, and in this area that could be injected. Obviously, the epidural injections that we have here along associated with that too. So these are the characteristics that we have seen with many of our patients. This was from the MMWR article that came out about it, and you can see the median age about 68, actually all the way down to about 23 years of age. Patients we've seen along the way. Majority of about 70% female with it. Meningitis is seen in the majority of cases like that, but again, not all of those. Stroke has been associated with it, but also the intra-articular injections that we see, and we can see abscesses associated with that too, and septic arthritis. The primary clinical sign that we're seeing, again with the meningitis, is the headache, fevers associated with nausea like that too. And we have seen a couple patients now, and I'm sure at St. Joe they have many patients, a stroke associated with it too. This is the kind of the timeline again, the onset of symptoms associated with it. The first onset they could duplicate with it is that back to August 18th, the injections were stopped. They were around the 26th of September, and then they have actually progressed from there too. So with fungi, they obviously, most of you know that they can even be broken down into yeast or molds. The common ones that we're seeing with this are actually molds, very uncommon in the CNS infections like that. In fact, I don't think there's been any cases of, in the literature of the causative pathogen, in this case, causing that. You can see the different nomenclature and the way it's broken down here too. So first, audience participation question. You can raise your hands. So what fungus or fungi has or have been isolated from the specimen so far? So 1, Aspergillus, 2, Cladosporium, 3, Extrahylan, or 4, all of the above? So okay, 1, what do you think? Yeah. Aspergillus. None? Okay. 2, Cladosporium. 3, Extrahylan. Okay. And 4, all of the above. Okay, so we have some educated people out here, which is good. So it is all above. The index case, interesting enough, the first case that was out there, they actually were able to isolate Aspergillus from that, and we have not had a case since then associated with it. So that was a case out of Tennessee. There was 1 case of Cladosporium associated with it, and all the other cases that they were actually able to identify a pathogen or a fungus with it have been the Extrahylan with those. So the answer is all of the above. So this is one I actually put in extra, I think from the last time we did the slides. These are, I believe, as of November 1st, I was able to get this off the CDC website, and it shows a number of cases again. So Cladosporium, Aspergillus, only 1 case a piece, and Extrahylan, then a majority of cases, obviously, out there. So this is a picture of Extrahylan. This was actually done at our lab, rather than taking it from the CDC. I was able to get a picture. Russ Hansen is one of our microbiologist techs in the lab, and he sent this to me, and he was extremely excited, and I was extremely excited. Our resident was extremely excited too, along with it. And you can actually see the spores. The spores with it. Move this. It's just there you go, right here. Oops. Move this. And down here in the hyphae, you can see associated with that also. So it's a very good picture of what's really occurring out there. And again, if you go on the CDC website, you can see this and other pictures associated with it too. And I'm sure it's St. Joe, they've had a number of these too, but I was pretty excited when I saw this. So what is Extrahylan? Well, I'm not going to go into any great depth with it because I don't know a lot about it, and I'm not sure if a lot of people do. So it's considered a brown-black mold, really environmental. It's in water, grasses, soil like that. It's, as I stated earlier, it has not been associated with any other CNS infections with this. And again, this is the predominant, as I stated, pathogen with the outbreak itself. So the primary antifungal agents we're using for this, you can see it broken down on the type of fungus with that. But for the majority, for the Extrahylan, we're using the Voriconazole, and we're using amphotericin. Now, initially, some places we're using in combination with that. We've only used it in 1 patient right now, and we're concentrating. I'm going to skip that one. Concentrating primarily on those patients that are, again, meningitis, using the Voriconazole. And these are very severely sick, and then we're actually using a combination of amphotericin B liposomal as well as Voriconazole IV associated with it. So this is an interim CDC guidance that actually came out. And what do we do for exposed patients with this? What if they don't have any symptoms with it? Again, it's kind of a watchful waiting associated with it. We don't need to go in and start antifungals prophylactically on these patients, as well as we don't need to do spinal taps in all patients that have had the injection like that. Now, if they do even have mild symptoms associated with it, you need to refer those patients to the primary care physician. They will probably send them to the ER or the EKG associated with your institution, and then they'll probably be doing spinal taps. We've looked probably easily done over 150 at our institution over the last month like that too, and I'm sure, again, St. Joe's done many more than that. So again, some of the interim guidance associated with it for the CNS or paraspinal infections versus the joint infections. We're again using Voriconazole 6 milligrams per kilogram every 12 hours. And that's usually IV. Again, we can go down to oral if we need be. That's the case. We did have a problem getting it in for a little bit, some of the products. If the patient is very sick, again, then we can use the liposomal amphotericin B at higher doses, 7.5 milligrams per kilogram, associated with it every 24 hours like that. Now, for the joint infections, we're still using Voriconazole. We're using it 6 milligrams per kilogram, but only for 2 doses. Then we're backing off to 4 milligrams per kilogram after that. And then really monitoring Voriconazole levels associated with it too. So why Voriconazole? Why not one of the other azole agents itself? Well, this is actually from Dr. Kaufman's article that she had in New England Journal of Medicine, just came out about a week and a half ago now. She explained that, with really good points, that we've all had much more experience than with the itraconazole and posaconazole, at least at our institution. It's available as IV or PO, while the other agents are not. The PO serum levels are pretty good, and its bioavailability of about 96%. The CSF levels are about 50% of the serum levels, which is really pretty good. And again, levels in the CSF and serum above with Voriconazole seem to be above the CSF needed for most molds like that. And then lastly, neither posaconazole or itraconazole achieve really great levels in the CSF itself, and they're really erratic absorption associated with it. So this, again, I have to thank Kim for sending me this information from St. Joe. They had a protocol together. This was back on, they developed this, I believe, in October 12th. Right, okay. It goes over the loading dose associated with it. It goes over the maintenance dose associated with it. I'll let you read this. Again, what they looked at for dosing, and we had this concern right from day one, what about those obese patients? Because we see, obviously, a lot in Michigan. We see a lot in Traverse City, too. What if they're morbidly obese? What do we dose on? Do we dose on actual body weight, ideal body weight, somewhere in between their adjusted body weight? I've got an article that actually Dr. Kraft was co-author on and explained that. But you can see here that St. Joe, and we have adopted this also based on that article, that probably if they're under 35 for a BMI, then we can use a actual body weight. If they're equal to or greater than 35 for BMI, then we'll probably use a dosing weight. You can see the formula here, which we usually use for aminoglycosides of vanco also with that too. One note that here they have cyclodextrin, which is in IV Voriconazole. It states here it can't be used in patients with renal impairment. The most recent article on that that came out of New England Journal of Medicine by Dr. Kaufman indicates, excuse me, even though we may be using this in renal dysfunction patients, there's no good correlation between that and a significant renal dysfunction associated with it. So what she's saying is that if we have renal dysfunction already in a patient and we think we're going to progress, then maybe we should use it. But on the other hand, it's not going to make things worse with it. So they're recommending if the patient really needs IV Voriconazole, we can continue with IV Voriconazole, even those patients with renal dysfunction. This actually goes in then again to maintenance dosing associated with it, and with the correcting clearance like that, as stated before, with the oral with that too. This is a study that was done in 2008 by Pascal, and they looked at the somewhat dose response curve as well as toxicity curve associated with it. And you can see in the graph A that there's a really good cure sort of success rate with levels excuse me, between 1 and 5. 1 and 6 with this too. But as you get higher than that, that's when you start seeing, again, toxicity associated with it. And definitely, I was talking to Kim beforehand, that's where we're seeing toxicity. We're really seeing a lot of, obviously, visual toxicity, but a lot of visual hallucinations with it. I had a patient the other day that in every room we have a calendar on the wall, and this month on the calendar there's a picture of a chipmunk. And it had his mouth filled with acorns. And the patient I was talking to said, for the last couple of days, I've been seeing that chipmunk jumping down and jumping back up to that calendar. So I said, okay, I think we probably need to modify your dose a little bit, because definitely there's a great correlation between neurotoxicity and the blood levels associated with it too. And this was a patient that we actually could back up to 4 milligrams per kilogram at that point. This is the article that I alluded to, and again, Dr. Kraft was one of the co-authors with this too, and it looked at, retrospectively, in a cohort study at the University of Michigan. They looked at a number of patients in two different groups. They looked at those morbidly obese patients, and they also looked at pretty much normal body weight, anywhere between 18 and 24.9 for a BMI. And then they looked at the dosing associated with it. They were dosing 4 milligrams per kilogram. And then they looked at blood levels associated with it. There was a good correlation of, obviously, with really high blood levels when they were looking at those obese patients versus those patients that were dosed with 4 milligrams per kilogram with a lower BMI with that. So they stated that, again, that probably the best way to go with this is to use either ideal body weight or adjusted body weight in this population of patients. And again, St. Joe adopted this, and we also adopted this over a period of time too. Not initially, but over a period of time, again, as we progress. So I think my time is almost up. And when I really wanted to come to conclusion, again, we're seeing a number of patients with this. I'm not sure how many other hospitals are seeing this. Obviously, we're seeing a lot in Southeast Michigan. The primary agents that we're using, again, Voriconazole is number one. Amphotericin B is the agent that will be used either in combination with that or especially in those severe patients. In monitoring Voriconazole levels, even though it may take a few days to get back, is probably the best way to monitor therapy in these patients too. And really, you need to counsel these patients about, and I did mention that drug interactions. It's a huge concern with these patients because of the, again, CYP, P450 system and the drug interactions associated with that too. So again, I'll hold off on doing any questions until the end, and thank you.
In October, the CMS started penalizing hospitals with high readmission rates. So if you look at the readmission rate for the general population Medicare patients, so those patients over 65, the readmission rate, 30-day readmission rate is about 17.7%. The end-stage renal disease readmission rate is double that at 33.9. So we spend a lot of money taking care of these patients, and these patients come into our hospital a lot. So it's important that we're able to optimize their drug therapy when they come in. Another way to sort of look at that financial picture, on the left here, sorry. Okay, so the end-stage renal disease population only is 1.3% of the total Medicare population, but they chew up 7.5% of Medicare dollars. So there's sort of a disproportionate share of the Medicare dollars that 1.3% of patients use. $47.5 billion per year we spend on the treatment of patients with end-stage renal disease, including those patients on hemodialysis. So there's lots of patients, we spend lots of money. Again, they deserve our attention. Just the first question sort of to think about, and as we go through, you'll get the answer here. Which of the following influence drug dosing in hemodialysis? Drug characteristics, the hemodialysis procedure itself, the patient, or all of the above? Okay. Again, as we go on, I hope to demonstrate that all of those things, the drugs, the dialysis procedure itself, and the patient themselves, all influence how we are going to dose these drugs in hemodialysis. So this is a really busy slide. It talks about some of the very basic pharmacokinetic considerations, absorption, distribution, metabolism, elimination. I'm not going to read through all of them, but I'm sort of going to point out some of the ones that are most important. When we look at drug interactions, you know, the average dialysis patient is probably on 11 or 12 different medications every day. Now that's not 11 or 12 doses, that's 11 or 12 different medications per day. So there's obviously a great potential for drug interactions, both metabolic drug interactions like with the isoenzymes, et cetera. Plus if you think about the oral iron and the phosphate supplements, those are interactions that can interfere with the absorption of drugs. So absorption and drug interactions is probably one of the key things to remember. When we talk about distribution, a basic pharmacokinetic principle, we need to remember that these patients are often fluid overloaded. So we may need to adjust our dose for a drug that has increased water solubility. So they may have a higher volume of distribution because they have extra fluid on. They also have alterations in tissue and protein binding that we may need to take into account for when we're dosing them. As far as metabolism, probably the biggest thing that we need to worry about is
accumulation of metabolites. So there are metabolites that accumulate that are active, and sometimes that's good because we can use less drug to get the same effect. But we also have to worry about the accumulation of toxic metabolites. Think of the classic meperidine. The normeperidine metabolite is responsible for the toxicity, the neurotoxicity in dialysis patients. So we need to avoid meperidine altogether. Not because of the parent drug itself, but because the metabolite accumulates in a dialysis patient. And obviously elimination is very important because if they're on dialysis, they don't eliminate drugs. And also, again, keep in mind the elimination of the metabolites is also something to keep in mind. So another key pharmacokinetic concept when you think about hemodialysis patients, hemodialysis only removes free drug that's in the blood. So it doesn't remove drug that's bound to protein. It doesn't move drug that's distributed in the tissues. It's only free drug in the blood. So if you put that together with your pharmacokinetic knowledge, remember drugs that would likely to be removed with dialysis are drugs that have a low volume of distribution because they are right in the blood. They're not distributed in the tissues. Drugs with low protein binding, again, free drug is removed. Low lipid solubility, so they're not bound to lipids. They're not distributed in the CNS. High water solubility, again, high water soluble drugs are in the blood. They're able to be removed with dialysis. One of the basic premises, too, is that we have to think about the parent compound, how much of that drug is dependent on renal elimination. So if you have a drug that is all hepatically metabolized, it's very unlikely to be removed with dialysis. But if you have a drug that is at least 50% dependent on renal function for removal, then that is going to have a significant influence on how you dose it for dialysis. The other thing to consider is the molecular weight of a drug. So small drugs are removed with dialysis easily. And we'll show some graphical pictures of that and how to demonstrate that in a few minutes. My screen is very blurry. Is it? Can you see it? Okay. All right. All right. This is just to emphasize that molecular weight, and we'll talk more about it in a minute, but urea is very small. So urea is removed very well with dialysis, which is good. Then you sort of group those aminoglycosides, cephalosporins, kind of in that middle area. They're kind of medium sized. They're removed pretty well. But when you look at things like B12 or Vanco, big. Okay, so they're not removed as well with dialysis unless we have a filter that is set up to remove large amounts of these big molecules. And we'll talk a little bit about that in a minute. And then we also have beta-2 microglobulin. So beta-2 microglobulin is sort of a standard marker for something that's really big, like a big protein that won't be removed with dialysis. We'll talk a little bit about more about the molecular weight in a minute. We also have to consider pharmacodynamic issues. So there are drugs that have a special toxicity or sensitivity in patients with renal insufficiency. Think of cefepime neurotoxicity. Think of imipenem seizures. Okay, those are things that are unique to that patient with renal insufficiency that we have to worry about. We also have to think about the relationship between the concentration and the effect of that particular drug. So is it a drug like an aminoglycoside that has a concentration-dependent killing? We want a really high peak and then we want it to go away. Or is it a blood pressure med? If we have a blood pressure medication, we don't want peaks and valleys. We want a nice steady-state concentration and control the blood pressure throughout the whole 24 hours. Okay? All right, so we've talked about pharmacokinetics, we've talked about pharmacodynamics, and next we're going to sort of switch to the dialysis procedure itself. So I'm very familiar with how the hemodialysis procedure works because I've sort of been in dialysis for 106 years, as the speaker this morning said. But I'm not sure how many pharmacists are very familiar with it. So again, just a question to think about. Which of the following has the greatest influence on drug removal during dialysis? Is it how long the patient's on dialysis that day? Is it the blood flow rate through the dialysis machine, the dialysate flow rate, or the dialysis filter? So let's just graphically show you how the hemodialysis procedure works. So you'll start with an access, okay? So dirty blood comes from the patient. It goes through a bunch of pressure monitors, and it comes through the dialysis filter. And then it's cleaned, and it comes back to the patient, okay? That's the basic circuit. If you look at a dialysis filter, inside that dialysis filter are thousands of hollow fibers. And those hollow fibers actually carry the blood. Okay, so the blood is pushed through the hollow fibers in that dialysis circuit. All of those hollow fibers are bunched together in like a hard case, okay, which is the dialysis filter. And the dialysis solution sort of bathes those hollow fibers. So the solution sort of, we fill up the case with the dialysis solution. Okay, so there's hollow fibers surrounded by dialysis fluid. Graphically, if you start here, okay, so this is the dialysis fluid, and this is the blood. And this here is a semi-permeable membrane, which is basically the wall of that hollow fiber capillary. Okay, so dirty blood comes from the patient, and the small toxins, small drugs, can go through the little holes in the semi-permeable membrane and goes into the dialysis fluid, and then it's eliminated as waste. Okay, and the dialysis fluid is flowing this way, but the blood is flowing this way. Big proteins, big drugs, big uremic toxins can't fit through the holes in that semi-permeable membrane, so they're not removed with dialysis. There's no big green squares over here. No big green drugs, no big green toxins, okay? And those are going to go back to the patient, okay? So it's all the process of diffusion. So the things that are going to influence how fast that diffusion can occur, how fast is the blood flowing? If the blood flows past the dialysis fluid too quickly, we don't have time for the process of diffusion to occur, okay? Now, the good thing is that most patients don't tolerate that you cranking up their blood flow rate very high. And you can usually get it around 500 if you have a really good access. And unfortunately, if you have a bad access, it's around maybe 250. But it does influence drug removal. Dialysis flow rate. So how fast that clean dialysis fluid is flowing past the blood can also influence how much drug is removed. If it flows too fast, you don't have time for the drugs to diffuse across or the uremic toxins to diffuse across. And then how long are they on dialysis? Now, most patients are on dialysis for anywhere between 3 to 5 hours a day. So one of the things that you might want to look at, the problem comes is your patient was scheduled to go to dialysis and you already wrote the orders for post-antibiotic or post-dialysis antibiotics, and then guess what? They go to dialysis and their catheter clots and they get 0 dialysis for the day. So duration is obviously important. When you're looking at clinical trials on pharmacokinetics, drug removal, and dialysis, blood flow rate, dialysis flow rate, and the duration have to be defined, okay? Clinically, on a day-to-day basis, we don't make dosage adjustments based on the blood flow rate or the dialysis flow rate. We may make adjustments, again, in that scenario where they had something happen to their access and they've only got an hour of dialysis that day. But we do regularly need to make dosage adjustments based on the type of filter that we have. Okay. All right, so a filter has a package insert, and in that package insert, there's a definition for all of these fun things. So think about, again, diffusion. If you have a larger surface area for diffusion, more diffusion can occur. Okay, if you have a really small molecule that can, like urea, that can cross, urea clearance is very good based on the surface area. B12 clearance, B12 is really big, 1,300 Daltons. Vanco's really big, 1,600 Daltons. So when you look at that package insert, you're going to look at the B12 clearance and say, this is a molecule that they tell me the clearance is this, and Vanco is just about this big. So they'll also define high efficiency and high flux. Remember we talked about the hollow fibers being a semi-permeable membrane. So if they have little spaces, little drugs can go through, but little spaces, big drugs can't go through. So that space is kind of the pore size of the dialysis filter. All right, let me give you an example to sort of put this all together. So this is sort of the history of the Fresenius filters that we've had at Henry Ford Hospital since I started there almost 20 years ago. Surface area for all of these filters is really big. Okay, that's good because if you have a big surface area, lots of room for diffusion. Wee little drugs like urea, not drugs, toxins like urea, can be cleared very easily because it's a little drug going through a little hole, no problem. Okay. Big substances like B12, this is again the package insert for a filter. The B12 clearance from the F8 filters was only 76, but when we switched to the F70 and the F80 and the F160, the B12 clearance was much higher. So what does this mean clinically? When I started at Henry Ford and we had the F8 filters, we gave Vanco once a week because it was not removed with dialysis. Okay? When we switched to the F70 filter, we had to change our Vanco dosing strategy. So now we give a loading dose and then we repeat the Vanco after each dialysis. So hopefully you have a relationship with your nephrologist and your dialysis units and your centers, and you're aware of what type of filter that you use at your dialysis center because it can significantly impact your drug dosing, especially for these bigger drugs like Vanco. Okay. So finally I want to talk about some patient factors that influence how we dose patients in hemodialysis. First, we want to talk about the fluid status. Okay, so you have a patient that comes in very fluid overloaded. Your first attempt, and you're trying to control their blood pressure. So your first attempt to control their blood pressure may be to try to pull more fluid off of dialysis, not to increase their antihypertensives. Okay, so that's why it's very important to assess the fluid status of your patient. Residual renal function is also very significant. Most hemodialysis patients lose their residual renal function over the course of the first year on dialysis. So if you have a patient who's new to dialysis, chances are they're still making urine. Okay? If you have a patient who comes in and they say, oh, he hasn't been to dialysis for 3 weeks and he's still alive, he's making urine. Okay? So residual renal function can influence how you dose drugs in dialysis. So for example, at our institution, we sort of use a cutoff of more than 100 mLs per day. If the patient makes more than 100 mLs per day, instead of our standard dose of Vanco 500 after each dialysis, we go up to 750 empirically. Okay? Vein preservation is something that's sort of near and dear to my heart. If you think back to the dialysis procedure that we talked about, it starts with having access for the patient. So the patient needs to have an IV line that can support dialysis. Every time you put an IV line in, you risk infection, a blood clot, scarring in that IV line. So when you pull that out, you may ruin that as a future site for dialysis. Okay, so they may never be able to get an access in that location. And we sort of have limited choices. We can use the jugulars, subclavians, femorals. We've also had to put translumbar catheters in. But really that's not much, and especially in patients that are not a good candidate for a graft or a fistula to start with. Okay, so when we choose drugs for hemodialysis patients, if we can use oral, that's great. If we can dose drugs for just post-dialysis so that they can be administered after their dialysis session through their same dialysis access, that's great too. We need to avoid putting PICC lines in for home infusion and all that other kind of stuff if we can. Now, sometimes we have choices and sometimes we don't. But I tell the residents, the medical residents on the nephrology floor, not to order a PICC line until they talk to their pharmacist. If they're ordering a PICC line for antibiotic therapy, because we need to reevaluate their antibiotic choice and make sure that they actually require a PICC line. So I save 2 or 3 PICC lines a month easily. Okay, I'm not going to go over this in the interest of time, but this is sort of putting it all together. So if you have a new drug you're not familiar with, these are sort of the summary of the questions from pharmacokinetics, pharmacodynamics, patient factors, dialysis factors that you should sort of work your way through. Okay? Now, again, the good thing is most of the time what we do is just go to some reference and look up the dose. But all the information that we've talked about so far, pharmacokinetics, pharmacodynamics, drug and dialysis characteristics, all of that information is what sort of makes your guidelines that you go look up. So, which of the following is the best resource for drug dosing information in hemo? Institution-specific guidelines, manufacturer's information, the primary literature, or Bennett's tables. So, for all the students and residents, this is probably the one time that I will say, don't use the primary literature, okay? And I'm going to make your case for why. This is sort of my hierarchy. If I'm looking up a drug that I don't know anything about, this is where I'm going to start. I'm going to look at our institution-specific guidelines, which, by the way, are usually based on the primary literature. But I'll look at institution-specific. If I can't find the drug there, I'm going to look in the Bennett's tables, which we'll talk about in a minute. Then I would look at manufacturer's information or primary literature. And the reason I don't put primary literature and manufacturer's information first is because I don't want to have to look it up. It takes too long every single time. You know, I want a quick reference. So if we talk about institution-specific, some other reasons that it's important to consider institution-specific guidelines is, number one, it's going to account for formulary agents. So if you tell your physicians or your pharmacist or your residents, use this as a resource for drug dosing and dialysis, and you only put the formulary agents on that list, you're automatically going to guide them in the right direction for which drug they should pick, okay? The other thing that's important, that you can also include information from any medication safety events that are unique to your institution. So for example, at Henry Ford Hospital, we've had this ongoing issue with acyclovir not being dose adjusted for renal insufficiency. So we have all these cases of neurotoxicity, and as much as we fight and yell and scream and pound our fists, it still happens. So our institution-specific guidelines include the information on acyclovir dosing. The other thing that you can do that sort of helps save time is if you have institution-specific guidelines, you can build in there delegated authority from your physician providers for you to just go ahead and change that dose automatically. So it saves you a phone call. Hey, can I change the ranitidine from twice a day to once a day? Like, why are you making that phone call? Okay, if you need to write that in your institution policy, you can go ahead and just change that without calling. Okay. The other two we're going to talk about in a minute. You can include other institution-specific data, or you can include diagnosis-specific data on your institutional guidelines. I'm going to skip this for time. This is an excerpt from our Henry Ford Hospital renal dosing table, and I talked about incorporating med safety events. So we have acyclovir. We have all of the acyclovir information based on the diagnosis. And so across the top is the degrees of renal insufficiency, the dosage recommendations based on infection. And then just because we still had issues, we actually moved the reminder that when you are dosing acyclovir, you dose it based on lean body weight. So it's right on our table. One place to look it up. The other thing that I mentioned is that you can include institution-specific information. So if you look up Piptazo dosing in Micromedics, or drug your reference of choice, it's going to start with 2.25 grams Q6, right? Our susceptibility for Piptazo at our institution is horrible. So 2.25 Q6 has never been an option. Okay? Our starting dose is 4.5 Q6. And actually, it was probably about a year ago that we changed it to this. It was 4.5 Q8, we had to bump it up to Q6. So this is another example of how you can include institution-specific information right in your adjustment guidelines. Okay. Has anyone ever heard of Bennett's tables? Are you guys familiar with this? Okay. Bennett's tables are called Bennett's tables because William Bennett is one of the editors. It's Drug Prescribing and Renal Failure is the name of the book. It's a little reference book. Okay. It's available at this website, and if you just Google it under renal drug book, this is the information you're going to get. So this might be hard to see in the back, so I'll kind of walk you through it. It talks about the percentage excreted unchanged, and it tells us that 75 to 95% of cefazolin is excreted unchanged. Remember I said any drug that's more than 50% renally eliminated, we need to think about adjusting the dose for dialysis. Talks about the half-life normally is 2 hours. In an end-stage renal disease, it's 40 to 70. Plasma protein binding is kind of high, but the volume distribution is really little. So remember when we talked about drug characteristics, a low volume of distribution, increased water solubility are drugs that can be dialyzed. This is a fun part. This talks about the normal dose. So it says the normal dose is 250 to 2 grams Q6. So kind of a wide range. So when you're going to use these tables, what you need to think of is what is your institution's normal dose, or what is the normal dose based on the indication, okay, to start with. And then it tells you whether you're going to change the dose or the interval. Then it gives you the recommendations. So if GFR is greater than 50, 100% of the dose. GFR is 10 to 50, still 100% of the dose. And the GFR is less than 10, which is a dialysis patient, 50% every Q24 to 48. One of the other things, too, it'll talk about supplementing for dialysis. Remember I talked to you about avoiding PICC lines if possible. This is sort of our standard recommendation for patients who have methicillin-susceptible Staph aureus or methicillin-susceptible Staph epi. We routinely do cefazolin just post-dialysis. Okay, we avoid nafcillin, getting a PICC line, having every 4-hour nafcillin. We avoid vanco, just save vanco for when we actually really need it. The one thing I would caution you about as far as the supplement for dialysis, there are some drugs that will say like imipenem, 250 milligrams every 24 hours, and then 125 milligrams supplement for dialysis. Most of the time what we do, there's no reason to give a drug and then dialyze it out and then have to give a little bit more. We just schedule it for Q24 hours in the evening. And then we avoid that whole supplement for dialysis issue. It doesn't make sense to waste drug. Okay. We talked about this already. Okay, so hopefully at the conclusion here, you have a better understanding of the cost of end-stage renal disease and why we need to focus on these patients. And we've talked about drug, dialysis, and patient factors to consider. And then I've made a case for you to all go back to your institutions and develop your own institution-specific hemodialysis drug dosing guidelines. Thank you very much.